Alright, welcome to Road to 250. So today we're just going to do a bunch of practice questions to end the week. And so let's get right into it with question number 1. So you have a 65-year-old man brought to the ER due to a crushing chest pain radiating to his left arm, diaphoresis, dyspnea, and fatigue. His wife said the pain started 8 hours ago, but it was tolerable. ECG revealed an ST segment elevation in leads 2, 3, and AVF, troponin level or troponin 1 and T, as well as CKMBs are elevated. The patient's admitted and treated with oxygen, nitroglycerin, beta blockers, aspirin, and ACE inhibitors. 4 days later, he started complaining of a chest pain and dyspnea. Echocardiography reveals an outpouching of the inferior wall of the heart. For the next 2 hours, the patient's BP drops to 70/20, and he dies. Which of the following is the most likely pathology leading to this patient's death? Mitral valve prolapse, papillary muscle rupture, pericarditis, ventricular aneurysm, ventricular pseudoaneurysm rupture.
This is 4 days post-MI.
Correct. Yeah. So this guy's probably got a
Pouching of the inferior wall of the heart.
rupture of some sort. I would think ventricular wall rupture, but papillary muscle rupture. 4 days later. So this is like the timeline of post-MI issues.
Correct. So this is going to test you. So if you want to go through this now or after you guys guess an answer, we can go through each of it.
E.
Okay, I have a guess for E. E?
It's yeah, let's go with E.
E
Got
is
it.
the
Oh,
correct answer.
Oh.
nice.
So in this case, you guys were right. I mean, he's definitely got an MI because ST segment elevation. So let me ask you this. Which leads? So the leads are 2, 3, and AVF. So where is the MI? Which location is the MI?
Inferior?
Okay.
Yeah, inferior.
So what's the artery that does the inferior?
Left. Oh god, why can't I think of the name? Is it circulating? No.
Circumflex?
RCA.
Right, circumflex.
What? Right. That does the posterior one?
Right coronary does
Inferior.
the inferior one.
Okay.
So lateral circumflex is the lateral side, and then the left anterior descending does the anterior septal, which is lead 1 and lead 2, and I think also lead 3 and lead 4. Okay, and I guess the biggest thing that you can take is this outpouching of the inferior wall of the heart. Because there's an outpouching and it's 4 days after, that's why it's a pseudoaneurysm. If it was a true aneurysm, which is this one, ventricular aneurysm would be a true aneurysm. This would happen 2 weeks to several months after an MI. All right, so let's go down the timeline because we're just going to review this, right? So what is the biggest concern 0 to 24 hours post-MI? That complication-wise that the patient suffer. So in this case, you're going to look for ventricular arrhythmias or heart failure or cardiogenic shock as the complications that you would see. Between 1 and 3 days.
Some sort of pericarditis?
Correct. So post-infarction fibrinous pericarditis. So that would be this answer right here, which is why this is not true because this happened 4 days after. And then 3 to 14 days later is when you're going to see what?
Pseudoaneurysm.
pseudoaneurysm, but yes. In first aid, if you look at page 294, it says you can also see a free wall rupture. So the papillary muscle rupture can occur in the same timeline, but these two things are hand in hand. So papillary muscle rupture and mitral valve prolapse always work hand in hand. But when you look at the echocardiogram, you don't see any symptoms of a mitral valve prolapse. So I'm going to go to this page right here. This is the answer why, explanations for all of them. But as we discussed, he has an inferior wall MI, and these are pseudoaneurysms or false aneurysms, and they result from containment of the myocardial rupture and are unusual complications post-MI. So these will contain your epicardium, pericardium, and hematoma. So why is it not mitral valve prolapse? Well, it occurs post-MI, secondary to ischemic injury, and rupture of the papillary muscle. So in which case we didn't see, but then the symptoms would be a sudden volume overload of the left atrium and ventricle, and that would lead to left ventricular filling pressures to be increased, which we did not see, when we did the echo or electrocardiogram. So again, like I said, papillary muscle rupture and mitral valve prolapse kind of go hand in hand, and there was no evidence of this. Pericarditis, as Pete mentioned, usually occurs 1 to 3 days post. And then the ventricular aneurysm occurs post-MI, but it's usually later than the false aneurysm. So these are true aneurysms, and they rarely rupture, but they can lead to mural thrombus, arrhythmias, and heart failure, and these usually occur 2 months post-MI. What is the other thing that we're worried about several weeks to months after an MI? What's that syndrome called?
Hurler Syndrome.
Correct. Hurler Syndrome. So in that case, those occur later. So that could be another question that you can get. So any questions about this question?
So I guess the takeaway from this question is the timeline really matters for the answer.
Yeah. I think the biggest thing is you want to make sure you want to keep in mind of the details of what they're stating, because I've seen many questions where that timeline is the only thing that kind of differentiates one answer from another, or helps you differentiate one answer from another.
Yeah, because if they had said 4 weeks later, you would be thinking Dressler's, but they said 4 days, so you got to be thinking.
Right.
That's the timeline.
Any other? All right, so we'll move on to the next question. So this is going back. So an 8-month-old boy is brought to the physician because of developmental delay and inability to hear and see. Physical exam reveals a cherry red spot on the macula, progressive neurodegeneration, but no hepatosplenomegaly. Which of the following substrates linked to the pathogenesis of the disease will be accumulated? So read the question carefully.
D.
Yeah, what's your guess?
Alright, so we're talking. Oh, actually, I'll wait.
Yeah, so here the big thing you're thinking about is cherry red spot. You're also looking at neurodegeneration, developmental delay, and the inability to hear and see.
Yeah,
but this is the key over here.
That's the key right there.
So I'm not asking about the enzyme, but what substrate is accumulated. It's a second order question.
I'm against D. I don't know.
Then you would be correct. D is the right answer.
Talk about
all right. So let's go through these real fast. When this is not a substrate, by the way.
It's not associated with hunters and hurlers?
Correct. Which one?
Hurlers. It's the
Hurlers.
enzyme.
Hunter's is iduronate sulfatase. This one is iduronate. So what would accumulate in Hurler syndrome?
Heparan sulfate.
Heparan sulfate or dermatan sulfate. So in Hurler syndrome, what are your symptoms that you're really kind of looking for?
You're going to look for visual acuity decreases.
Yeah, so there's going to be corneal clouding. That's one. Corneal clouding. You're also going to see hepatosplenomegaly. So in this case, there is none, so you can rule the first one out right there. You'll still see developmental delay, and then airway obstruction is another one. Okay, where would you see sphingomyelin accumulated in which disease? Niemann-Pick. So what is the enzyme that's deficient if this is accumulated?
Sphingomyelinase.
Sphingomyelinase is correct. So how do you differentiate? Because Niemann-Pick, you're also going to see a cherry red spot. So the big differentiation between this question and why it's not B is the hepatosplenomegaly. Right. Everything else kind of will be exactly the same. Now let me ask you this. What kind of histologic cells would you see in Niemann-Pick disease?
Is it foamy macrophages?
Yeah, foam cells. You'll see foam cells, which are latent, lipid-laden macrophages.
Lipid-laden.
Yes. Yeah, but you're going to look for foam cells. And they're literally a big giant cell. It looks like a foam, I guess, and has no nucleus. But not really good at drawing, so we'll move on.
Yeah, close enough.
Mucocerebroside. Where would you see this guy?
Gauchers.
The one on the top of the chart.
Yeah, that's the top of the chart. This is the most common disease you're probably going to see, lysosomal disease with the sphingolipidosis. What's the enzyme deficient in Gaucher's disease?
Glucocerebrosidase.
Yeah, glucocerebrosidase. All right, so let's talk about some of the symptoms that you would see in this condition.
There is hepatosplenomegaly.
That's wow, that sucked. Hepato is correct. You're going to see pancytopenia. What is the one thing that kind of helps you differentiate with many questions with Gaucher's disease? It's the avascular necrosis of the femur. That's, to me, has always been a key sign with this one. You can also see osteoporosis. And what kind of cells would you see in this one?
Also lipid-laden macrophages.
Right, but they're not called foam cells for this one. They look like what? They are Gaucher cells, but they look like crumpled tissue paper.
Oh, tissue paper.
Yeah. So when you crumple tissue paper, whatever that ball looks like, that's what the Gaucher cells look like on histology.
All wrinkled.
All right, so this one is, sorry?
All wrinkled and has all these lines and things in it.
Yeah, I mean, I'll try to draw it. It like, it's all wrinkly. Yeah, there you go. Alright, so this last one.
It is
Fabry disease.
Fabry's, yeah.
Fabry's disease. So what's the enzyme deficient in Fabry's disease?
Alpha galactoside something.
Sidase A.
Okay.
Yes. Alpha galactosidase A. All right. So now with Fabry's disease, there's an early triad and then a late progressive disease process. So what do you see early in the disease process? So you get episodic peripheral neuropathy, angiokeratomas, and hypohidrosis.
Lack of sweating.
Yeah. And then the late, it will progress to renal failure and cardiovascular disease. I have it all written out here. I just wanted to go through this. So there's here to review. So you can do that. But I kind of went through everything just verbally. And so if you're ready, we can move on to the next question.
Yeah.
All right. So
One of my questions? Okay. We have a 40-year-old man presents to the emergency department with difficulty breathing. He's feeling worse over the past few days. Woke up this morning gasping for breath. He also complains of productive cough, which he suspects is preventing him from breathing better. Physical exam, there's bilateral rales and rhonchi. X-ray of the chest shows diffuse interstitial infiltrates. And sputum samples confirm a diagnosis of pneumocystis jirovecii pneumonia. Additionally, HIV tests come back positive. He's placed on several antiretroviral medications to manage his condition. Several weeks later, he returns to his physician for a routine complete blood cell count, which is normal except for a platelet count of 70,000. His physician suspects that this laboratory finding is caused by one of his HIV medications, which acts by blocking protease in progeny virions. What medication could have caused his thrombocytopenia?
Yeah.
So it's the protease blockers. So those are the Navirs. That's correct. So Indinavir?
Indinavir gives stones, I hear. Okay. Protease inhibitor.
Because didanosine is an NRTI, correct?
Yes.
Efuvretide is
It's a fusion inhibitor.
Raltegravir is a integrase inhibitor.
Mm-hmm.
And zidovudine is also a protease inhibitor. Is it not?
Zidovudine.
Zidovudine is an NRTI.
Yes.
Oh, okay, yeah. Not bad. Okay, then Indinavir?
Yeah. So that alone leaves Indinavir as the answer.
It causes aplastic anemia? Or bone marrow?
Well, it definitely causes thrombocytopenia. I'll give it that. And you are right about it causing kidney stones. That's the more special one.
Here for you.
It can also cause GI intolerance, hyperglycemia, lipid problems, etc., etc.
This is the one that, like, fat distribution throughout the body?
Yeah. And yeah, you guys are right about the other ones. Didanosine and zidovudine are NRTIs, and Efuvretide is a fusion inhibitor, and raltegravir is an integrase inhibitor. So just on that alone, you know that Indinavir is the answer. Pretty nice and straightforward there. Any questions about this question?
Well, I guess I gotta go over heart drugs again. Good question.
Yep, I'm good.
Cool. So, go on to the next one.
Oh, man.
Retrospective study is designed to look at the differences in smoking in male and female populations. In a sample of 100 men and 100 women, 25 men and 40 women admit to smoking a cigarette in the past month. What is the odds ratio of a woman smoking compared with that for a man smoking?
Really? Oh.
So when we think about odds ratio, you're thinking about yes over no. So if we're comparing the woman to the man, you're going to do yes over no for the woman over yes over no for the man. So just think about
So
that.
25 plus 40 over 200? Or no, sorry. 75 plus 60.
It's odds ratio. Do you remember the formula for odds ratio?
You're going 1 over 4 for men as the ratio to 4 over 10 women, right?
Yeah.
Is that more what you're talking about? Oh, it is the ratio of woman to man. So we're going 4 out of 10 compared to 2.5 out of 10. That's...
It's not going to be out of 10.
Well, you just said yes to no. So
yes to no.
Is it C?
So if 25 out of the 100 is yes, how many out of the 100 is no? 75. So it's going to be 25 over 75 for the men and 40 over 60 for the women. So it'll be 40 over 60 over 25 over 75. But if you draw it, and then you can just do the little cross multiplication there to get your answer. Well, if you go ahead and go to the next slide. I drew it out for you. So we have our 40 women smoking, 60 non-smoking, 25 men smoking, 75 non-smoking. So the odds ratio of a woman smoking is the 40 over 60. Or the ratio for the women smoking. And the man smoking is 25 over 75. So then you can just do the AD over BC thing. And then you will get 2. So the ratio is 2 to 1.
My answer is still going to be E.
Okay.
You just have to add in parentheses due to idiots.
Interesting. Oh, man. Thank you for mathematics.
Thank you for ruining my evening.
It was a simple example just to walk through this.
No, it's a good question. I just don't think of this stuff as, I guess these are easy points.
This is a simple example, and we're like straight up like monkeys trying to figure this out. Like,
You just have to draw the chart. You draw the chart and you'll be fine.
Yeah, I was trying to figure that out, but you were talking.
You know what? Yeah, I'm sure this is going to come in handy every single day in your practice. Day, you will be like, oh, you smoke? You know, there were 24 other guys in here that just told me they smoke too.
You know the odds ratio of women compared to men out of the 100 women I surveyed today? 2 to 1.
Where's my patience on the day for you? So, okay.
All right, next one.
Yeah, it's the next one. A 25-year-old medical student has a positive purified protein derivative test, also known as a PPD. Results of her chest x-ray show no signs of active disease. For treatment of latent tuberculosis, she begins a 9-month-long medication regimen. 2 months into treatment, she complains of the sudden onset of fever, rash, and swelling of her joints. What is the intended mechanism of the medication that caused these adverse effects?
So she's on INH.
Okay.
So synthesis of folate is not the right answer. Synthesis of messenger RNA is not the right answer. Peptidoglycans would be in penicillin, from what I think. So that's not right. So I'm going to stick with C because E does not make any sense in this case.
And Pete?
Yeah.
Alright, and C is correct. This person is on isoniazid to decrease the risk of developing active TB. And yes, it causes a decrease in the synthesis of mycolic acids that make up the cell envelope of Mycobacterium tuberculosis. Usually for the 9-month treatment of latent tuberculosis, it is isoniazid by itself. But you can do combined drug regimens. That'll be for a shorter amount of time, not necessarily the 9 months, but yeah. And the possible adverse effect of taking isoniazid is drug-induced lupus, which is kind of like what you see with the fever and the rash and the swelling of the joints, etc., etc.
Oh. What drug would be synthesis of cGMP?
That one is hydralazine.
Oh.
Causes vasodilation through increased production of cyclic GMP and may also cause lupus-like syndrome, but is not used to treat TB.
I think Ryan Seaguar also did. Never mind.
I think so too.
The Ryan Seacrest medication.
Any other questions about any of the other options?
Oh, peptidoglycan is Vanco, right? Sorry.
Yeah, it can be Vanco, any of the penicillins, cephalosporins, monobacterium, any of them.
Diala.
Oh, that's the specific one.
And decreased synthesis of messenger RNA is referring to rifampin.
Right.
And
that would cause yellow, orange.
But you gotta make sure that a patient is taking methionine.
Mm-hmm.
B6?
Yes.
To avoid
peripheral neuropathy.
And decreases synthesis of folate is obviously any of the folate inhibitors, but which of the folate inhibitors do you use for a similar species?
Dantrolene, leprosy.
Dapsone.
Yeah, that's right, leprosy.
But yes, for Mycobacterium leprae, you would use Dapsone.
Dantrolene is the
Ryanidine receptor.
Alright, next.
Mm-hmm.
Okay.
Oh, this is mine. Okay. 5-day-old boy brought to the ED for easy bruisability. He was born at 35 weeks gestation via vaginal delivery at home. There's no certified care provider present at the delivery, and mom did not receive any prenatal care. Oh, yeah, it's my sister. I probably said this the last time, too. The boy is breastfed exclusively. There's no family history of bleeding disorders. The infant's lab values are within normal limits. Bleeding is present around the umbilical area, but the rest of the exam is unremarkable. Platelets 270 grams, PP 26, and APTT 42. Which of the following is the most likely cause of this infant's condition? So, he's 5 days old, he's bleeding, and mommy is a hippie.
Mommy's hippie.
That actually is, I remember, I think I wrote this question myself or snagged it from something, but I remember I had a convo with my dad specifically making this question geared towards my sister.
Well, it's not factor 7 deficiency, right?
No, because, and why not? Why can
Well, you would have to have a vitamin K deficiency for factor 7 not to work, correct?
Well, it's not factor 7 because if you look at the PT and PT, well, factor 7 is just PT. It's a little elevated, but not super elevated.
PTT is normal as well, right?
Yeah, they're both normal. Platelets are normal, PT's normal. PTT.
So it's not von Willebrand's because you would have bleeding disorder with that.
Right.
Cirrhosis of the liver doesn't make sense. So D?
Whoever's in charge of the PowerPoint, you can push it, yo. Why is it D? Mom's a hippie. What did she not do? What does every newborn...
Folate.
No. What does every newborn get a shot of when they get born?
Vitamin K, right?
Vitamin K. Yeah, exactly. Every newborn gets a shot. Vitamin K. But this lady probably, she squatted in a field and thought that was fine. So this kid's got easy mobility. And where do we get our vitamin K from? Which newborns don't have.
Gut bacteria?
There you go. The normal gut flora, which newborns don't normally have. So very good. So yeah, any of these other ones, destruction of the platelets, E. That one would be like TPP or something like that. All these others would manifest later on. And what you notice, this kid's only 5 days old, and he's just brought in for bruisability. Many of these other ones, minus A, all of these others would manifest if this kid had an accident where he was cut on the arm or something and would not stop bleeding. This kid was bruising easily. He doesn't have proper coagulation factor. But yeah.
Good question. All right, next.
Question? All right. God damn, you idiot, Pete. Why does he put a better background on this? 34-year-old woman presents to ED with a 6-month history of recurring epistaxis. That's a $10,000 word for nose bleeding and easy bruising. She has experienced approximately 2 to 3 epistaxis episodes per month during this period. She bleeds and eventually stops following the packing of the anterior nares. She has no past medical or surgical history, takes no medication. She's never been prego, but notes that her menstrual periods have been more heavy than usual during the same 6 months. She denies headaches or changes in vision. On exam, she is afebrile, has a pulse of 78, BP of 119/82. On dermatologic exam, she has diffuse areas of petechiae under her tongue, on the extensor surfaces of her forearms, and on posterior thighs bilaterally, none of which are elevated or palpable. Ab exam is negative for splenomegaly. Lab exam shows a BUN of 13, creatinine 0.8, white blood cells 8,000, platelets 24,000, hemoglobin 14, hematocrit 42, PT 14, PT 27, bleeding time 11, and what was the most likely diagnosis?
So bleeding time is high. Platelet count.
Platelets are super fucking low. Platelets, lower range of normal is what? 150,000 to 200? So,
150 to 250?
Yeah. No, 150 to like 400,000.
Oh, yeah.
Okay, so she's got some sort of serious thrombocytopenia. So...
She has microhemorrhages, right?
Correct.
So, how do you differentiate immune versus thrombocytic or thrombotic thrombocytopenia?
And if I had my little thingy, I would tell you that it is. Abdominal exam is negative for splenomegaly. So
it's thrombotic thrombocytopenia. Purpura. So it's D.
There you go.
I was gonna say C, but now I'm not so sure.
Because C, wouldn't you also see some sort of viral infection prior? Or viral illness or drug reaction or some sort? Secondary, if it was?
Not necessarily, but if you had a viral infection, that would probably induce the ITP, and you would see splenomegaly, because what is ITP? It's the spleen, or an autoimmune disorder where the body thinks that the
macrophages are eating the platelets.
Exactly. Your platelets are evil to your body, as I remember it. So your platelets keep getting stuck in your spleen, being churned up and spit out, but it backs up, so you're going to have splenomegaly. Also, ITP typically will present early in life. This is a 34-year-old female. TTP normally presents in a female, and I actually don't think I put it in here, but normally, again, if I remember from Dr. Barone's teachings, he says that it's a hot female crazy. So but she's right. So I don't know.
Sorry.
Can we, whoever's in charge of PowerPoint, we hit it? Oh, fuck. Really? With no splenomegaly?
Alright, so immune, let me pull it up. Immune is
anti-GP2B3A antibodies. You'll have splenic macrophage consumption of the complexes. Can be idiopathic or secondary to autoimmune disorders, viral illness, malignancy, or drug reactions. You would see decreased platelet count and increased bleeding time in both immune and thrombotic. For thrombotic, you would also see a pentad of neurologic and renal symptoms, fever, thrombocytopenia, and microangiopathic hemolytic anemia.
Well, there are renal. BUN is 13, creatinine is normal. And I think BUN is, it's also normal.
Yeah, that ratio is normal.
So white blood cells are also normal, right? Because they shouldn't.
So normal white blood cell count is 4,500 to 11,000. So WBCs are also.
So there is no thrombocytopenia in this patient.
Yes, there is. She's got
there is.
24,000, and she's got.
Oh crap! No.
Platelet count's low. Hemoglobin's normal. Hematocrit's normal. PT.
And she had thrombocytopenia. Fuck. Man, of course, this is my question, because I didn't look at this shit. Why couldn't it be TTP?
Okay, so nosebleeds, heavier menstruation.
Well, whatever that all has to do with affect the cheapest. Well, what platelet count? Well, I am sorry. I don't know. The an incomplete one for me. And I would look up the answer because I'm looking at first aid. I don't have proper notes. I guarantee you the answer is in my Kaplan pathology book, but I didn't bring it with me. So I don't know how.
Kaplan pathology. Kaplan pathology.
And yeah, it says right here, Yash, ITP, common due to viral illness, like you said. So I don't see, and it doesn't.
Okay. Chronic ITP is usually seen in women in their childbearing years and may be the first manifestation of a systemic lupus erythematosus, clinically characterized by petechiae, ecchymoses, menorrhagia, and nosebleeds.
So what is TTP? Did I totally screw that up and say that TTP is that more common in early ages then?
And TTP just says most often affects adult women with the characteristic pentad of signs that I said before, with the fever, thrombocytopenia, hemolytic anemia, neurological symptoms, and renal failure. So she doesn't have those two.
The difference here is she doesn't have a fever, she's not psycho, but
she does have nosebleeds and menorrhagia, which are signs of ITP.
Alright, sorry guys. My bad.
That's okay, we talked it through.
Okay.
Still works.
So, ITP, afebrile, PTP, psycho, fever, PMS. Sorry to all our female viewers.
Next.
Yeah, please, let's finish this. This is horrible. Oh god, I'm bleeding one. Alright, a 6-year-old boy is discharge epistaxis. He's been febrile for about 10 days now. The parents are having difficulty controlling epistaxis for about 2 days. Well, if people don't walk away knowing what epistaxis is, by the end of this holy shit. The patient has also had easy bruising for the past few months. His medical history is significant for several recurrent pulmonary infections requiring hospitalization for parenteral antibiotics, and previous sweat chloride test was positive. The boy's father recently lost his job, and they've been having difficulties in obtaining necessary medication. Population studies are PT 25, PTP 35. Which of the following factors is most likely to be abnormal in this patient? So what does this kid have?
So PT is elevated and PTT is normal.
So to use Dr. Barone, males with an increased PTT. Males with an increased PTT.
B?
I'll probably stick with that too.
Wait a minute. This kid obviously has cystic fibrosis. He's on for 10 days. Bleeding. So you're saying which one did you say?
Factor
eight. Seven, sorry.
because it's extrinsic pathway, and that's the shorter one, so that's PT. Because the other one's longer, so it's PTT.
Yeah.
So I think it's B.
Give it a shot.
Woo.
Woo. Okay. So literally from lab values, we can move on with that.
Yeah, because your factor 8 would be PTT. That's hemophilia A.
Okay.
Is that it?
Woo. Yay, review shit. Alright. Hold up, guys.
So for your last question, just to explain it to our audience, you said the guy.
Oh, there's not bad. I didn't realize it was much.
That's okay. He has cystic fibrosis, as we've mentioned, so thus he will have vitamin deficiency or fat-soluble vitamins A, D, E, K. And then you can get an acquired coagulopathy with vitamin K deficiency in factor 7. So now we're done.